So hi everyone, welcome back. My name is Basir Kunduzi. I'll be your host today. I'm one of the co-founders of the page Cut This Stitch, and also organizing these talks for your benefit. Hopefully there's of some use. We had three talks already. One of them is on YouTube, the other one's going to come up soon. Today with us we got one of my old friends and one of my teachers actually when I was a medical student, Mr Adil Ahmad, who's an ST7 at the John Radcliffe Hospital in Oxford in trauma and orthopaedics. So he's almost a consultant. He's kindly agreed to give us this very important lecture on pediatric fractures. So hopefully it will benefit all of us. This lecture will be recorded, and hopefully we'll have his permission to put it on our YouTube channel as well. So you can check it out afterwards. As always, if you have any questions, there's a Q&A section. So if you just put your questions there, and at the end, I'll go through them with Mr. Ahmed, and hopefully we can answer as many as we can. So without further ado, Mr. Adil Ahmad.
Hi there. Okay, assalamu alaikum. Thank you very much for that introduction. Let me just share the screen. So, good evening. So, pediatric fracture. That they said in John Radcliffe, and over the past few years, I realised actually that as a junior doctor, probably one of the most worrying things would be encountering pediatric fractures. Not only because they're kind of small kids with broken bones, but also because you have to kind of manage both the parents, and their worries can be significantly more so worrying, and there can be more anxiety with the parents than the actual kind of fracture necessitates. So we'll look at some of the objectives, particularly with how children's fractures are different, discussing the common fractures in children. We'll go through some of the physeal fractures and what kind of things to look out for, particularly when you're a F1 or F2. So part of the growth plate. This is kind of one of the images of a distal radius X-ray, and you can see there are certain components to that, particularly the epiphysis, the physis. The physis is the growth plate, and the metaphysis and the diaphysis. And we'll learn why the physis, this particular growth plate here, which is present in almost all bones, what the relevance is when it comes to clinical, the clinical kind of arena. So specific to children, there are a number of fractures which are specific. You've probably all seen some of this either through presentations or maybe clinical placements, but things like green stick fractures, or as well as torus fractures, these are buckle fractures, and plastic, and so deformation, and by that I mean particularly plastic deformation, and that just means that kids' bones are very bendy, and so you can end up doing a lot of damage to kind of a patient can sustain a lot of damage, particularly a child, without actually their bones breaking. And so often when I go down to a trauma call in A&E, if somebody tells me that a kid is fractured ribs, for example, that's quite serious, because a child, particularly under the age of 10, there has to be a significant amount of force to actually fracture, whereas plastic deformation, which is bending of the bone, can happen much more frequently. And here we see an example of torus fractures, and this is exactly what I meant by plastic deformation. So you can see the bone is bent and it's not looking like it should do, but it hasn't fractured and it hasn't caused this type of green stick fracture either. And then there can be physeal injuries. And our physeal injuries, this is an ankle X-ray AP view, and you can see what we call a small little fracture in the epiphysis. And so we'll go on to the classification of these epiphyseal fractures with regards to types 1 to 5. So why are they different? Well, they're different from adults for a number of reasons. They have thick cartilage at the ends of the bones, and that thick cartilage you can't see on the x-ray. They have a very thick periosteum, and that's the reason they remodel quite well. So not only are the bones quite good at remodeling, but the blood supply is extremely good, and that's thick periosteum, particularly when I'm doing, say, an open reduction in internal fixation of a bone. You can see this thick periosteum, and it's almost like a thick layer of rubber all along the bone. And it houses all the kind of small blood vessels that gives it immense potential in terms of remodeling. They're also more elastic, and by elastic, as we described, you can kind of think of elastic as plastic as well, in that kind of they tend to plastic deformation, and so they lead to these incomplete fractures or even the plastic deformations. And the growth plate we established is one of the main reasons, is because it is one of the main reasons for the excellent potential for remodeling. And we'll look at some of these special growth plate injuries later. Quite often the ligaments are stronger than bones in children, and so often you'll have avulsion fractures. An example of this would be a tibial tuberosity fracture, which is much more likely in children compared to adults, or for example in adults, a differentiator would be an ACL injury. So in adults, you know, you've seen footballers get ACL injuries. In children, particularly adolescents, you don't tend to see a mid-substance rupture of the ACL. You see more a pull-off of the tibial spine, which is the insertion of the ACL onto the tibia. So, this is just an example of the power of remodeling. In these slides, you can see this radial shaft fracture, which actually was completely off-ended in the radioulnar plane. And you can see this is what we called, there is minimal bayonet, or there is bayonet apposition. So this means overlap of some degree, but it's in line. So there's no angulation, but you can see over the course of treatment, so this is probably a couple of weeks in, and then you can see a couple of months in, you can see it's completely remodeled to almost what looks like normal bone. And if you gave that a few more years, it probably would look exactly like a normal radius. Again, the power, remarkable what the human body can do. You can see this proximal femoral shaft fracture here. It's got this butterfly fragment as well. Look at that, you know, over the course of a few weeks, and that's probably a year down the line. You can see it looks completely like a normal femur. So the power of remodeling means that we can accept more angulation and more displacement. So there may be wonky bones that we end up telling kids and their parents that actually we don't need to operate. And you can imagine the look of dismay on the parent's face when they've got a very wonky forearm in front of them, and you know they're kind of completely surprised that we're managing this without any operation. But it is a lot of it, pediatric fractures are a reassurance that these do heal and they do go on to remodel, and you can see this again here in this process. And it is worth noting that remodeling occurs at a much better and much more efficient rate distal, so as close to the physis as possible. That's as close to the growth plate. This is why diaphyseal fractures may necessitate fixation, even for ones that normally we would say leave alone, particularly as you as you're approaching puberty and kind of young adult years. So that's what we discussed. So it's better remodeling near the growth plates. So again, most fractures in children heal very well, whatever you do. And the key thing here is to reassure parents that quite often they may not require an operation. You know, you don't necessarily need to do that as an F1 or F2, but certainly after discussion with the orthopaedic registrar, if you can get hold of them, if they're not too busy in theatre, then you'll often find that, you know, a lot of these can be managed non-operatively, and sometimes the onus may be on you to discuss this and relay this to the parents. So we discussed a lot of fractures, lots of different variations of fractures which may occur in children, which can be managed non-operatively. I tend to, even though I've written conservative here, we should really state non-operative and operative as a differentiator, because conservative means, you know, people can misconstrue as, for example, a plaster of Paris. Now, plaster of Paris may necessitate application in the operating theatre, and so that would be an operative intervention, not simply a conservative. And the reasons are for, you know, if operative interventions necessitate possible general anaesthetic, the risks associated with this, and the risks associated with any perioperative process. So unstable fractures, we can see that both bones at the same level. You can imagine if you a lot of so the forearm and the leg, the tibia and the fibula, can all be demonstrated as a polar ring. If there's one break in one, then as long as the other is not broken, which is very unusual, then that potentially could be managed conservatively. Now, quite often when one is broken, there's always another break at some other level. And this may necessitate fixation or certainly management in the form of something more than just a simple plaster that can be applied in ED or in the plaster room. Oblique fractures are also more unstable. Spiral fractures, these are both called length unstable fractures, because, for example, in a tibia, if you've got an oblique or spiral fracture, if you were, say, to weight bear on it, then it will end up displacing. Whereas if you imagine a transverse fracture, the transverse fracture is a horizontal fracture, and that the fact that it's in that plane means that even if you try to weight bear in a well-molded plaster, the bone ends are in contact and they're not going to slide as they would do, say, with an oblique or spiral fracture. Comminuted fractures are also going to necessitate fixation, and also sometimes for parents, in a way, shouldn't say this, but for example, there are certain fractures which can be, say, borderline between whether you would operate and not operate, and a lot of these may end up being completely fine without an operation, but because the level of clinical deformity we see, i.e. the bendy forearm we see, parents may be completely horrified if we do not, you know, operate and try to make a bendy forearm straight. And so sometimes we do this, but again, these are normally the borderline cases. So closed reduction is still one of the most common ways to treat any fractures. Closed reduction and casting particularly. Good casting is important. Casting has its benefits in that kind of it prevents the need for an operation. It allows stabilization of the fracture. It allows the holding out of the fracture, the reduction of the fracture, but it does not allow for any small tweaks that we may want to do to enable perfect anatomical reduction. And that may be needed, particularly, for example, in physeal injuries in children and in adults in articular fractures. But it does necessitate regular follow-up, so it's important to have a good plaster room at your disposal where you can send these patients to regularly followed up, make sure their casts are looked at, make sure there's no areas of thermal necrosis when they're put on, make sure there's no cast burns, the cast has not become loose, because if it's become loose, then it ends up displacing the fracture. And quite often that's why we end up checking patients at weekly intervals to ensure the fracture has not been displaced. So surgical treatment, there are a number of ways to treat these: K-wires, intramedullary nails, plates, and external fixators. K-wire is probably one of the most common ways to treat certain fractures that have displaced significantly and angulated. They're very effective. Normally use kind of 1.6 millimeter K-wires up to 2 millimeter K-wires in children. And you probably, well, you almost always need to add a plaster afterwards, just because obviously there's wires poking out of the bone and skin, and you want to cover these, but also because sometimes you just want to give it a bit more hold. The K-wires are excellent in terms of holding out a fracture to a certain position, but they're not great when it comes to rotational stability. And sometimes that's the reason we then end up putting 2 or 3 extra wires, depending on where the fracture is. These, yeah, it says percutaneous or open on the slide, but realistically, you know, you only need to open the area if there is significant displacement, which you cannot achieve with closed reduction. And actually in children, most of the times you can probably achieve a good closed reduction. One example where you might need to kind of make a small mini open incision is a both bone forearm fracture or a radius and ulnar fracture. You can see of this patient's forearm, there is significant angulation. When we talk about angulation with radius ulnar, it's actually quite a nice way to talk about the apex. So here you can see which way the apex is heading. So here there's an apex kind of volar, but if the apex was dorsal, then you can say apex dorsal angulation or apex volar angulation. That's something more in terms of how you describe fractures. But you can see that this fracture is significantly displaced. Even if we try to reduce it by closed means, it may work, and you're able to put these elastic IM intramedullary nails or rods in, and these elastic nails, normally kind of 2 millimeter or 1.6 millimeter, they're inserted just proximal to the radial styloid here, growth plate, and just distal to the ulnar, the proximal ulnar growth plate here. But sometimes, obviously, if you can't reduce this fracture, then you do need to make a mini open incision along where the fractures are, and then just kind of, you know, sometimes even just use your fingers to pass it through, or use the aid of small kind of retractors to see the wire go through into the other fragment. But you can see they've done quite well here in terms of fracture healing. It's gone on to union, and these can then come out normally kind of a couple of months after you put them in, about 6 months. You don't want to leave them too long. You don't want to leave them for too long, because it can be actually quite difficult to then take them out. You need to make sure the ends are not too buried, even that you don't want to, you need a fine balance between metalwork irritation, but also the fact that you need to then fish these out later. And so if you bury them too much, you might even completely lose them. Right, so plating, yeah, for overweight children, for fractures again that we talked about, that may be difficult to manage with just wires alone, need more rotational stability. Plating of femurs can be done particularly in kind of the larger patients, but there will be a large scar and there is a large incision, and for children that can be a bit of it can be quite a big kind of traumatic event, and especially for young girls, not being sexist, but it can cause a scar as well. Hence the reason why we sometimes, if we are going to plate, we do what's called bridge plating or MIPO technique, which is minimally invasive plate osteosynthesis. And that's small stab incisions, you can see here in the thigh, to aid the entrance of the plate, usually from the distal end, and we tunnel it under the fat, under the muscle, and along the periosteum all the way to the top, which has been done here. We may make several other incisions, some for the screws, but also some to aid placement of the plate, so we know exactly that it is in the middle of the bone and not kind of sitting off one way or the other. Other fractures, we can put external fixators on. These can be very useful, particularly in contaminated wounds that you don't want to fix with a plate or intramedullary rod, which may become infected. And so you would want to just hold the fracture hold the fracture with this kind of frame until kind of plastic surgeons intervene if there is a wound there, or if it's very contaminated. In fairness, in pediatric patients, we often sometimes just use this as a treatment modality alone until the fracture heals, depending on the age of the patient. So common injuries which you've probably come across are clavicles, radius, forearm fractures, supracondylar fractures, epiphyseal injuries, non-accidental injuries, which we will talk about as well. But if we look at one of the most common types here, supracondylar fractures of the distal humerus, you've probably seen loads, or you will see loads in A&E. And it's normally a fall on an outstretched hand. You can have two types. There are either the extended type supracondylar or the flexion type supracondylar injuries, and by that, the extended or flexion aspect of it relates to the distal fragment and the way it's sitting. But quite often they cause injury to one of the three. Well, I'd say quite often. I'd say if they are going to cause injury to the nerves, then they will cause injury to the AIN nerve, which is a branch of the median nerve in the majority of cases, in the extended type ones, and the anterior interosseous nerve, that is, and that innervates the deep flexor forearm muscles. So that's pronator quadratus, flexor digitorum profundus to the radial 3.5 digits, and flexor pollicis longus, and that can be tested by a simple kind of the OK sign, so if the child can do that. And then the ulnar nerve is quite often injured in the flexion type injuries, and the ulnar nerve can be tested with kind of checking for fingers crossed to see if the child can do that. And the radial nerve can also be tested with a simple kind of thumbs up. That tests the EPL tendon, which is innervated by the posterior interosseous nerve, which is a branch of that radial nerve. So you can actually test all three nerves in one simple go in that fashion. In terms of their motor function. So why does it happen particularly here? Well, basically it flares out. It's a weak part of the bone, that supracondylar area of the humerus, and it's susceptible to injury, particularly with kids kind of on trampolines, etc. Sometimes there is nerve or vessel injury, as we describe. Vessel injury, again, rare, but can happen. And these can sometimes be open, which then necessitates kind of usually discussion with plastics or vascular if there is a concern with the brachial artery. So you can see the elbow joint here. You can see the anterior fat pad and the posterior fat pads, and these are the fat pads we're talking about. When you may have noticed A&E talking about anterior fat pad displacement or posterior fat pad displacement, all it is there are normal fat pads sitting here which can be displaced. Now, sometimes they're displaced very minimally without a fracture, and that's the way they normally sit. But if there's significant elevation, then I'd say, yeah, there's an anterior posterior fat pad. And in in here, for example, you can see when that breaks, the fat pad displaces a significant amount. So you can see both anterior and the posterior fat pads have displaced significantly. And that's because there's normally blood in the joint pushing these out. And that just shows that as well. So again, you can see significant displacement of the fat pads, both the anterior and posterior part. So X-rays, certain lines that you need to know about in the pediatric elbow, the anterior humeral line, which is a line down the anterior aspect of the humerus, as it suggests, should intersect the distal 1/3 of the capitellum, or the middle 1/3 of the capitellum, and you can see it passing quite well there. You can see here it's not passing, and so that would be abnormal. So that's one line that you should know about in any, if all else fails and you're not sure what's going on, if that looks abnormal, there's definitely a fracture, and there's definitely something that you need to discuss a senior, that you need to discuss with the senior. So they haven't talked about the radiocapitellar line here, but we'll just briefly mention that the radiocapitellar line is a line between the radius and the capitellum. So the radius essentially should always be facing the capitellum in every view. In the AP, lateral, oblique, it should always, as you can see, it faces the capitellum here, faces the capitellum here, and it faces the capitellum here. So it's always facing the capitellum. So Gartland's classification describes supracondylar, probably a bit above what you need to know for finals or as a junior doctor, but nonetheless, it's a good, simple way to describe. Gartland 1 is an undisplaced, Gartland 2 normally has a posterior cortex intact, and Gartland 3 is completely displaced. And there's a query about whether there's a Gartland 4 or not. 4 talks about it being rotationally unstable, but I think by the time you're at type 3, it looks fairly obvious that this needs something more than just a simple plaster. The reason it needs immediate care, you can see that degree of swelling there, the bruising. You don't want to leave that for a long time. You want to be discussing that with a orthopedic surgeon fairly quickly. But it's important to make sure you've documented the median nerve, radial nerve, anterior interosseous nerve, and we described how to do that. They missed the ulnar nerve here, but we described how to do that. So again, thumbs up for the radial nerve, fingers crossed for the ulnar nerve, and the OK sign, and try not to kind of break that OK sign. Ask the child to do that, and that's for the anterior interosseous nerve. But also the brachial artery. The best way is to check radial pulse. Is there a radial pulse or not? Sometimes you can still have a radial pulse despite there being some tenting or spasming. Checking the perfusion is important, and checking the capillary refill. So supracondylar fractures need immediate care. The delay causes more swelling, as we discussed. It causes more difficulties in reduction. So we don't tend to leave the kind of type 3s overnight as much as we used to, and that's predominantly because both guidelines have come into effect to say why you should take someone to theatre. Both guidelines are the British Orthopaedic Association of British Orthopaedic Association of Surgical Trauma guidelines that come into place to discuss why and when you need to take someone into theatre. And I'd say that even though those guidelines don't actually talk about the fact that you necessarily need to take a patient with a supracondylar fracture in a well perfused kind of patient, well perfused hand with a good radial pulse, a lot of time surgeons, because of the fact that this can become increasingly difficult by the time you operate in the morning, would take these to theatre. Undisplaced ones you can simply just cast alone and apply an above elbow plaster. Displaced ones, as we discussed, will need surgery for a closed reduction initially. If that fails, then an open reduction with a lazy incision over the anterior aspect of the forearm. Usually not done though. Closed reduction normally works, and fixation with K-wires. And the K-wires, the gold standard of the 2mm K-wires, according to the BOSE guidelines. So you can see this 6-year girl who fell from a swing, very common scenario, falling from swings or trampolines, sustaining this supracondylar fracture in this weak area of bone, and it actually was reduced and wired with 2mm wires, looks like, and actually you can see over time it has gone on to unite and gone on to do quite well, that and remodeled very well. So there's just an example of the wires in which direction we put them in. They're crossed bicortical wires. You can use divergent lateral wires. Neurovascular injury must be ruled out. That's important because of the kinking of vessels. I think that the reason for this slide is to demonstrate an example of Volkmann's ischemic contracture, which occurs if there is a disruption in the brachial artery, and which has gone unnoticed, and which is, to be honest, rare in the current kind of era. There will always be, you'd hope, there'd always be good monitoring of the pulse and the nerves before and after the operation to ensure that this doesn't happen. But if this did go on to then cause myoneural ischemia, you can see the muscles, if they become ischemic, they contract and they end up with this contracture, which can, in the foot, it may not be debilitating. Certainly in the hand, it can be. And delayed complications, so you can get cubitus varus, which is a gun stock deformity. Again, you don't see many of these here. You can see that deformity there. Quite often, actually, it doesn't really cause much bother to the child. And sometimes these patients are brought into exams, for example, for the FRCS, and they're actually doing quite well. In contrast, the cubitus valgus deformity, which is the opposite way, can progress and cause what we call a tardy ulnar nerve palsy, and that's because the ulnar nerve is stretched. If you imagine that a hand, instead of kind of that forearm pointing in, is pointing out, the ulnar nerve is coming medially behind the medial epicondyle, and as a hand pushes out laterally or in that cubitus valgus pattern, that ulnar nerve is then being stretched. So that can cause problems. Now, the lateral condyle fractures may be easily missed as well. These are injuries, certainly, that can be even missed by the orthopedic SHOs. And sometimes you may need more than just an AP and lateral view. You may need an oblique radiograph, internal oblique radiograph, to look at the fragment particularly, and it may need fixation even if it's not displaced. And that's because some of these, or quite a lot of these, go on to a non-union, which can be troublesome. So the forearm is radius and ulnar. It's basically a joint that can perform a supination and pronation. That's why it's important to get an anatomical reduction when we're plastering or when we're reducing fractures. But having said that, again, bayonet apposition, which is overlap of the bones, is still completely acceptable in a certain age, less than 10, and these still go on to remodel very well. On the other hand, older children, particularly with angulated fractures like this, do need a good kind of regular follow-up if they are being managed in a cast. And if they're unstable or then displaced, then quite often they need surgical treatment, and that would be in the form of intramedullary nails. Plating can sometimes be used, particularly in the older child. You can plate both bones. And again, that's someone who's approaching adolescence or slightly older, it may be more of a viable option. The intramedullary nails are quite good, but probably not able to withstand the amount of force, say, from a adolescent child onwards. So yeah, 14, 15, I wouldn't really put an intramedullary nail in someone of that age, whereas 12 and under, probably consider that. Again, it depends on the child. Sometimes you have children who are very small for their age and their growth plates are still, open even at 13. And so then we may consider TENS nailing. So fracture dislocations, you've got the Monteggia fracture, which you should know about, is the fracture of the proximal ulna with a dislocation of the head of the radius, and the Beidou classification is based on that in terms of where the head dislocates, whether it's anterior, posterior, or lateral. But the Galeazzi fracture is a similar type, but this involving the fracture of the distal third of the radial shaft with a dislocation of the distal radio-ulnar joint. So again, both these fractures just talk about the, or kind of relay the fact that the forearm is a ring, and if there is a break in one of the areas of the ring, you need to look out for a break in the others. So here you can see this, a fracture of the radial shaft of the radius. Funnily enough, inadequate views here of the X-ray. You might hear orthopods banging on about this, but clearly this is inadequate in that we can't actually see the elbow joint, but we can make out that this is probably a dislocated, the radial head is dislocated. And this is what they're talking about, that it may be missed if two joints aren't seen on the X-ray, and you can see here that actually it is dislocated. And so again, this is something that would certainly need surgical fixation, because a plaster probably not hold it, it would be too unstable, and really you want to get a good anatomical reduction of the ulna to ensure that that radial head then pops back into place. So the radiocapitellar line we talked about briefly previously, but again, it's another line similar to what, the anterior humeral line, which you can look out for. And the radiocapitellar line, again, is a line that's drawn through the center of the radial head, and it should pass through the center of the capitellum in all views. And you can see that being demonstrated in the images there. And if it's not, then potentially you've got a dislocated radial head. Now, Galeazzi fractures are a similar entity to Monteggia, but on the distal aspect of the forearm, and so they're associated with the fracture of the radius with dislocation of the distal radio-ulnar joint, and quite often the ulna is dislocated dorsally, which we can see here. This not only requires reduction of the radius, but also reduction of the distal radio-ulnar joint. Sometimes when we fix the radius, the distal radio-ulnar joint comes back into place and we don't need to do anything and it's stable. But if it's not stable, it may necessitate a pinning with some K-wires. Also, sometimes it may not even come back into place. It may not reduce, and that's because there's a tendon which is in its way, and that tendon normally extends to a digiti minimi tendon. So physeal injuries, about 15 to 20% of all skeletal injuries in children, 50% occur in the distal radius, and they can affect growth. So there are forms of the distal radius, the germinal zone or the resting zone, proliferative, the hypertrophic, and you've got the enchondral ossification here, followed by the primary spongiosa and the secondary spongiosa. So we're going to look at particularly the hypertrophic, well, the physeal fractures normally happen at this zone called the hypertrophic zone. It's the weakest part of the zone. This is a Salter-Harris classification, which you should be aware of, certainly for exams. So how I remember it is the actual SALT. So SALT, forget the E and then R, so SALT R. So if grade 1 is S, then you can see it's at the same level as the physis. So that's a fracture line through the physis. A is for grade 2, and A would be above the physis. So you can see fracture line exiting above. L is lower, so lower than the physis, and you can see it exiting lower. T is through, and that's through the physis. And as I mentioned, we missed out E and we go straight to R, and R is basically rammed. So that's a rammed injury where it's been forced, kind of the physis has been jammed, kind of pushed together. However, a lot of these injuries you're not really going to be able to appreciate at the time because there'll be no obvious discernible thing to look out for on the X-ray. And 75% are the type 2s. So the Salter-Harris ones at the same level as the physis. Closed reduction normally okay, but fixation might be needed if it's still unstable. Salter-Harris 2 needs a good stable reduction. Usually, to be honest, most times it can be closed, but sometimes may need some percutaneous fixation with the use of screws or wires. 3 is intra-articular, and this almost always needs an anatomical reduction with stable fixation with screws. You can see that there. And Salter-Harris 5, there's no treatment available because, as we explained, there's normally diagnosed in retrospect after a physeal or a kind of a limb deformity has developed. You can see the injured and uninjured wrist. So the injured and uninjured after premature physeal closure. So certainly there was some disruption of the physis here, which meant that it hasn't quite, the radial aspect of it hasn't developed as the ulnar has. And so you're lacking that normal 21 degrees of radial slope on that view. Again, you can see it here, distal femur physeal fractures are nasty injuries. Just remember that these injuries, even though they may be innocuous at the time or even mildly displaced, these often need anatomical reduction. And even after anatomical reduction, to be honest, outcomes are not great. They have significant, predisposition to physeal arrest and angular deformity. So lastly, accidental injuries and tumours, non-accidental injuries, so any femoral shaft fracture, particularly in less than 1 year of age, be raising suspicions of a non-accidental injury, as well as transverse fractures. Humeral shaft fractures are a similar group. Sternal fractures and corner fractures. Corner fractures are from traction and rotation, and then bucket handle fractures. Again, traction and rotation injuries. You'd want to be looking for other signs such as bruising, any rib deformities from old fractures, any cigarette burns, all the usual things you look out for NAI, but certainly make sure paediatrics are involved with patients like these if there is any suspicion, and there's normally a safeguarding lead in the hospital. So you can see some of the burns there. But Any non-accidental injury should be remembered for these things. So delay in seeking medical attention, mechanism which doesn't really fit with the pattern of injury, the actual location of the injury, a vague history, a varying history, or inappropriate parental attitude. And that can just take place in the form of a parent who's not really cooperating well, who's presented his child quite late, and sometimes just aggressive or a weird affect. Other features are failure to thrive, previous kind of NAI kind of case that has been raised with the same kind of family. Normally these get flagged up when the patients come in. And as we discussed, femoral shaft fracture is very unusual, especially in non-ambulant children. Also remember tumours. The tumours are very difficult to diagnose sometimes in kids because quite often they're related or very close to trauma. So there may be a history of trauma, a fall, etc. And everyone just brushes it off as actually that's probably just soft tissue swelling, or it's just, you know, it's nothing, X-ray looked pretty much normal. But actually, in hindsight, if you looked at some of these X-rays, there would be a suspicion of an odd kind of cortical irregularity, periosteal reaction. There may be sunray spicules, onion skinning, all these kind of typical signs that, you know, you always think about, you know, poor kind of zones of transition. That you would normally look for, but you haven't looked for this time around because you were focused on whether there was a fracture or not. So just remember to look at the bone, just, you know, and not just look for any lucent lines, look for any other areas which don't look completely normal, and flag it up to one of your seniors or the orthopaedic reg. You can see in this 12-year-old girl, she had a history of trauma. Everyone kind of brushed it off. It was diagnosed as a soft tissue injury, nothing really obvious on the X-ray, no broken bone, so it's all good. But actually 2 months she was still complaining of pain, and you can see now there's significant periosteal reaction. There is significant, well, there's a poor demarcation in terms of the lesion, which is a bad or poor prognostic sign. You can see some sunray spiculation, and you'd be worried about not a fracture, you'd be worried about a tumour, particularly something like a Ewing sarcoma, diaxial kind of tumour. So about 50% of the population in MER children, or fractures in children, are common. Compare it with the other side. Closed reduction often works well. Surgery may be needed, but don't think that these fractures act like adult fractures, and quite often they can be managed just without any operation. Supracondylar fractures certainly need urgent attention. A joint, so forearms, make sure you assess the forearm and the leg, the tibia and the fibula as a polo. You need to look for the alignment. You need to look to ensure there are no other fracture dislocations anywhere present. Remember the two lines we talked about on the elbow X-ray, the anterior humeral line and the radiocapitellar line. And in the lower limb, similar thing, it's still a polo, so, you know, make sure if there is a break on one area, looking at another area as well. But in the lower limb, we're also, we want to look for alignment, rotation and bend, but actually that's in all fractures, where generally in limb, any kind of limb fractures, we're looking at those. Epiphyseal injuries can be difficult to treat, and may lead to angular deformities, particularly with the physis involved. And always remember to look out for non-accidental injuries and tumours. And so I think that wraps it up. I'll just see if there are any questions.
Thank you very much, Mr. Ahmad. Can you see the Q&A section? Do you want me to go through?
So I'll just go through. So, do pediatric fractures present as often as adult? Yeah, I'd probably say they present, if not more than at least the same incidence. In fact, probably more, because despite me saying that pediatric fractures, they tend to undergo plastic deformation, up to a certain age, they do start presenting as fractures. And what I was talking about was more kind of if you're involved in a trauma call with a very young patient, a 3 or 4 year old, say, so under 5, and they've had, for example, rib fractures. Certain fractures are very unusual to find in kids. Rib fractures are one of them. And that's just because of the way the bones tend to plastically deform much more than they fracture. But other fractures are still very common. You get clavicle fractures, distal radius fractures, kind of toddler's fractures, which you may have heard of, which are spiral tibial fractures. So I'd say that they're very, very common, and you'll most certainly see them. The second part, it says, is it possible to do a thorough exam without painkillers and peds fractures? Or better to give something before you go about assessing range of motion? No, certainly. I think that's a very valid point. In fact, in most patients, whether it's peds or adults, I would always say ensure they have adequate analgesia before you begin to assess them, because quite often I find in A&E that children or adults have come through and they're lying in A&E with, holding their limb, because understandably A&E are busy, but they haven't been given painkillers. And, a simple thing to do as soon as you see the patient, if they haven't been given any analgesia, give them analgesia. It will make your job much easier in terms of when you're actually assessing them and assessing their, as you said, weight bearing as well. So you potentially could assess weight bearing for things like ankle fractures, which are stable, but without analgesia, you're not going to be able to do that. Another question was, do you take K-wires out after? Yeah, we take all the K-wires out after, depending on where the K-wire, what it's been used for. But normally kind of 4 to 6 weeks is when we take out all the K-wires. Please ask him to repeat the fat pad sign at the end. Okay, fine. So I'll just go to the bit. So can you see, is that in the way, or can you see the elbow? Hopefully you can see that. But so the fat pad here, if you can see the cursor, the fat pads are basically, they're pads held within the electron fossa here, and at the front here, which is a coronoid fossa. So these fat pads are normal. They are completely normal. Everyone has them. They're both anterior and posterior. And the only thing that would be abnormal is an elevated fat pad. So when people say, oh, I've seen a fat pad, well, you should do, because it's normal. So unless they say, oh, it's an elevated fat pad, and here you can see on the X-ray, so on this image first, you can see that these fat pads have now been displaced because there is a break in the bone, and that break has led to a blood clot or a hemarthrosis, and it's pushed out the fat pads, and that's what you see on, for example, this view. Now you can't see the fracture that well, but there's probably a fracture here, and it's displaced the anterior and the posterior fat pad, so they're not as obvious. So normally these fat pads look like they're very close to bone, or is not as obvious. So a lot of people mention fat pads all the time to me in A&E, and actually they're not displaced. So it's only relevant if you tell me there's a displaced fat pad. That would be an indication that there potentially has been what you're telling me is there's been an intra-articular, or there's been a fracture. And the reason for that is because that blood clot, that hemarthrosis, has displaced those fat pads we mentioned away from where they should be sitting in their appropriate fossas. Right, let's just go back to the questions. Sorry, is the finger cross sign for ulnar nerve? How do you retest for anterior? Yeah, so we'll just go by that again. So thumbs up is basically testing the radial nerve, and that radial nerve is innervated. That particular branch is the posterior interosseous nerve, okay, and that's thumbs up, so that's a very easy way, radial nerve. Then you've got fingers crossed, which is easy way for kids to understand, and that's ulnar nerve. And then anterior interosseous nerve is basically the OK sign. So you ask them to do that, and then you say, don't let me like break that OK, or don't let me break that. And that basically is the anterior interosseous nerve you're testing for. And that's because this is the flexor digitorum profundus of the index finger and FPL of the thumb. How do we know to use plating or iron nails or KYs? Okay, great question. Don't worry, at your state, I mean, depending, I presume we're all kind of either medical students here or junior doctors. You're not going to be assigned to particularly what we need to use. There, in fairness, the reasons for using specific modality when it comes to operating takes a few years to understand why and when. But in very simple terms, the KYs can be used for things like that. You just want some stability to hold the fracture for a short while, normally for 4 to 6 weeks in wrist fractures, sometimes even in distal fractures in children. Plating is for much longer kind of term. Sometimes even you keep the plates in children. And intramedullary nails, or the TENS nails, again, there are different modalities either for the forearm, the femur. I think getting into the complexities of when you use each particular one would be tricky to understand, but it's knowing that we can use potentially all these options. As a rule of thumb, it's good to think about children as the older they get, the more we probably end up operating, and the more we want to use certain stronger methods of holding the fracture, and the stronger methods would be plating or nailing. So in the younger patients, we may opt for K-wires or screws or things like that. As patients get older, we may think about plates and nails. Is wanting to seek a second opinion a sign of an AI? Wanting to seek a second opinion a sign of an AI? Is that second? Okay, so I presume you mean second opinion from the parents. Not necessarily. I mean, if they, it's a tricky one, because if obviously they've come into the department and you're concerned about an AI, then I think we'd have a duty to keep that patient there and explain why we're doing that, despite the parents might want to seek a second opinion. But I think because of the fact that it's a fracture, it's not elective work, it is under trauma, it's emergency work, so we don't expect parents to leave the department when they've been told that potentially the child may have an operation, and it probably isn't the right time to seek a second opinion. But if they want to seek a second opinion while the child's in the department, then they can do. But just be warned that, yeah, I think it's a good question, because it shows that you're thinking about the fact what kind of parents might do to try to avoid their kid being seen if they've been brought in. So I think definitely have that in mind. Good. Are there any more questions, or?
No, I think that's it. I think those are all the questions we've covered.
Yeah.
Thank you very much for this very informative lecture. It was very useful, especially having worked in A&E. I think if I had this lecture before, it would have calmed me a bit more when children came in with injuries. Yeah, so what we'll do is, if you have any questions, further questions, you can always follow Dr. Adil, Mr. Adil, I keep on saying doctor, on Instagram. We've put his Instagram up, and you can message him, hopefully, if that's okay with him. Also, as we'll put this lecture up on YouTube as well, so any questions we can get on the comments there as well, and hopefully get to him. So I hope it was beneficial. I hope it was useful to you guys. Yeah, and that's it. Thank you very much.
No, thank you very much. And yeah, as Bassett said, that if there are any questions, feel free to either email or Instagram, and hopefully I'll be doing a few more kind of tutorials, particularly on surgical training, and particularly for anyone interested in trauma and orthopedic surgery as a career.
Perfect. Yes, we'll definitely have you back. Thank you so much. All right, thank you.
Okay, bye.
Have a good evening. Bye-bye.